So, dear colleagues, dear friends, good morning. It's very my pleasure to be here, and I would like to thank all of you for this warm welcome. And this is my second time in Vietnam, and I really appreciate your welcome and congratulations for this event. Today, I have the honor to open this meeting with this presentation regarding the application of double stimulation in IVF treatment. I'm a gynecologist. I work in a private IVF setting in Italy, in Rome. I come from Rome, and I will try to share with you which is our approach when we manage infertility patients, and in particular when we manage poor prognosis patients. This is my disclosure. I think before to start with the presentation, it's crucial to understand which is the goal for us when we treat infertility patients. So in this picture, you can summarize all the important factors when we treat patients, when we treat infertility patients. Because, of course, we have to try to increase the cumulative labor rate for our patients. This means efficacy of the treatment. Efficacy means how many babies we are able to obtain when we treat infertility patients. But also, we have to try to improve the efficiency of the treatment. The efficiency means try to reduce the adverse event, try to reduce the time, try to improve the cost effectiveness of the treatment, and try to reduce the dropout rate. So all these points are very crucial when we want to manage infertility patients. So we know very clear that the number of the eggs is crucial. When we increase the number of the eggs during the stimulation, you can increase the cumulative chance for our patients. And so more eggs means more embryo. More embryo means more chance to get one or more than one baby. Of course, the number is crucial, but also the quality of the oocyte is crucial. And what does mean quality in our treatment? Today, we have two important things regarding two important parameters. One is the blastulation rate, because the blastulation rate represents an important indicator to assess the quality of the eggs, the quality of the sperm, and another important parameter is the aneuploidy rate, so which is the chromosomal status of the embryo. I want to show you the population that I treat every day in my centers, and I don't know in Vietnam, but when I discuss with the colleagues, I think we have the same identical problem. Unfortunately, we manage all the time patients with advanced maternal age. So look, only 20% of my patients are patients with less than 35. And the majority of the patients, more than 84%, are patients with more than 40. And so what can we do according with the population that we treat? And this is the number of the eggs that I collect in my center. So this means that if I have young patients, I can reach minimum 10 number of the oocyte, okay? But if I have advanced maternal age patients, the mean number of the eggs is 4.5 in patients between more than 42. And also the competence of this oocyte is lower. And as I said before, competence is the blastulation rate. And here you can see that the blastulation rate, if you have young patients in front of you, will be 40%. But if you have advanced maternal age, the blastulation rate will be lower, around 30%. This is the reason why, theoretically, if you want to obtain one competent embryo, one euploid embryo, in order to have more chance to get in pregnancy, theoretically, I need 4 or 5 eggs in young population, but look how many eggs I need in order to obtain the same identical goal. And this is the cumulative labor rate in my centers. Of course, if I have young patients, I have 62% of cumulative LIBOR rate for one treatment, but if I have patients at 44, 43, unfortunately, I have 5%. The question when we manage poor prognosis means patients with advanced maternal age, patients with low variable reserve, is that we have some point that we have to analyze. The question regarding the ovocyte, the time, and the dropout rate. Let's start with the ovocyte. With the stimulation, unfortunately, we cannot create follicle ex novo. The stimulation is crucial in order to promote the follicle development. If I have 10 antral follicle count, my goal will be to obtain 10 eggs, 10 mature eggs. And so the question is that what can I do? And how can we analyze the efficacy of my stimulation? For example, the ovarian sensitivity markers, the FOI and FORT, are very important to assess the quality of my stimulation. And today, if you look at the big data regarding the efficacy of the treatment in terms of number of the oocyte, when you use a recombinant product, you have a more cumulative chance. This means that the gonadotropin, the recombinant product, seems to be more efficacy in order to stimulate the follicle growth. And the question is that we can have some specific patients population, in particular poor prognosis patients, in which the FSH alone is not enough. And this is the reason why the LH activity seems to have a role in order to improve the folliculogenesis, in order to promote the androgen synthesis, in order to try to optimize the follicular growth. And the question is still open regarding the application of the recombinant LH or the ACG activity, but the data seems to be in favor of the application of the LH recombinant. The question is, if you have 3 eggs in patients at 40, unfortunately, we have 7% of the cumulative LIBOR rate. So eggs and age represent 2 important parameters to assess the possibility to have a baby. And you can use whatever you want. You can change the gonadotropin, you can change protocol, but at the end, you will have maximum less than 10% of the cumulative LIBOR rate when you manage patients at 40 and when you have few eggs. But if you look the Poseidon stratification try to categorize patients with a different age and with different different reason why we have few eggs. If you analyze the success for one treatment, of course, we have lower chance. But if you analyze the success up to 6 cycles, so if we try to change the narrative and if we analyze the cumulative LIBOR rate, not for 1 cycle, but up to 6, of course, you can reach relative adequate success rate also in this population. We know today that the folliculogenesis is extremely dynamic. So we have multiple follicular waves, okay, during one menstrual cycle. You can start in conventional way, and then we have the first follicular waves. This is the major waves, and this is the ovulatory waves. But also in the luteal phase, you can have another follicular waves. This is the reason why we can start in a randomly way when you have cancer patients, and when we don't have time, you can start at any time of the menstrual cycle. Or you can start some data, in particular coming from China, support the application to start in the luteal phase in patients with strong with poor ovarian reserve markers. But however, today we have also the possibility to combine the conventional approach and unconventional stimulation, in which we start in conventional way, and then we do the pickup, and then we restart again with another stimulation in the luteal phase. This is the name of the double stimulation syndrome. The goal of this approach is to try to improve the number of the eggs in a short time frame and improve the number of the embryo in a short time frame. So usually in our protocol, we start with estradiol priming in order to synchronize the cohort of the follicles. So we use a recombinant product. We use the LH in order to promote the follicle growth. We use agonist trigger. This is an important, crucial step. We do the pickup, we wait 5 days, and then we restart again with the semi-identical stimulation. So many protocol, many strategies regarding the double stimulation has been proposed. Look how many steps you can personalize. You can personalize the time when you start the synchronization. You can personalize the type of the gonadotropin. However, our group was the first that in 2016, the first time in 2018, we published the evidence that when you collect ovocyte from an ovulatory waves, you have the same identical competence in terms of fertilization, in terms of blastulation, in terms of the euploidy rate. In our group, we work a lot regarding this approach. We published some other paper regarding the application of the double stimulation in a multiple centers in order to make a convalidation of this approach. And we can confirm that when you collect eggs from an ovulatory waves in the luteal phase, you have the same identical competence and the same identical blastulation rate. And this meta-analysis showed that confirmed this data and showed that in the second stimulation, you can have 0.6 eggs more. This means that there is a positive effect in the second stimulation thanks to the first one. This is my data. This is the number of the Duostim protocol that we performed in my centers in less than 10 years. You can see here that the population candidate for this approach are patients with around 6 oocytes, with 4 or 5 metaphase 2. Of course, here you can see a huge number of the cycle that we performed up to date. We can confirm that the mean euploid blastulation rate when you take the oocyte from an ovulatory wave is similar. So this means that we have a good eggs when we collect eggs from luteal phase. And of course, this approach increase the number of the eggs in a short time frame, but we can confirm that in the second stimulation, we have more eggs compared to the first one, with the same identical protocol, with the same identical gonadotropin, with the same identical cycle. And the question is that why I have more eggs in the second stimulation in the same ovarian cycle? Because maybe the biomechanical effect of the pickup can improve the follicular cohort, or because maybe we have an endogenous priming thanks to the endogenous hormones, or because we have a change in the microenvironment of the uterus. This means that the ovary are more sensitivity in order to promote the follicular recruitment. However, we try to study all these putative reason why in the second stimulation we have more eggs, but this is what we showed. And another point is that thanks to this approach, we understood that there is not only an intercycle variability. So when we stimulate patients, we can have a different number of the eggs when we stimulate patients in different cycle. But also we have an intracycle variability. Intracycle variability means that in the same menstrual cycle, we can have different follicular waves with different potential. This is just an example. In Bologna criteria patients, so in very poor prognosis patients, in 54% we have more eggs in the second stimulation. In 31% we have less oocyte in the first, in the second one, and in 50% we have the same number. So this means that there is a variability, and the variability is something not related to the type of the gonadotropin, but it's something to related with the follicular waves. And you see the result when we transfer euploid embryo. So we have the same identical outcomes when we transfer euploid embryo coming from the first or coming from the second follicular waves. What about the dropout rate? The dropout rate is an important key performance indicators. I don't know if you know the dropout rate in your centers, but this is just an example. This is the retrospective data coming again from my centers. In Bologna criteria, in poor prognosis patients, the dropout rate is very high. It's very high. It's around 60%. So when you have patients with the poor prognosis patients with a few eggs with advanced maternal age, the dropout rate theoretically is very high because the patients, they want to try something different. And look also when the time when the patients come back to me to perform a second conventional approach. So this data coming from a conventional approach. Look, many patients lose more than 6 months to come again to me. And the question is that why? Why the patient, we have this very high dropout rate? This data coming from France. In France, we have a full coverage reimburse of the treatment. But again, also when the patients do not pay nothing, the dropout rate is 40% in advanced maternal age population and in patients with poor prognosis patients. And of course, the reason, we have many reasons. We can have economical reason, we can have a psychological reason, or we can have a personal reason. But this is something that we have to investigate. Because what we have to try to explain to our patients is that the fertility is not one treatment. The fertility journey, the IVF treatment is a journey, is not one treatment. This is the reason why we have to try to explain to our patients that in many cases, one cycle is not enough to obtain the pregnancy. Indeed, when we look the dropout rate in Duostim protocol, you can see that when I am able to explain to my patients that we perform 2 stimulations in one ovarian cycle, the dropout rate is 0. So because the patients are motivated to do another stimulation in order to increase the cumulative chance. Look again when we do two conventional stimulation, the dropout rate is really high. So this means that we have to try to improve our counseling. One cycle is not enough in many patients. This is the reason why at the beginning of the story of the Duostim, our goal was to individualize patients candidate for this approach before. Now we decided to go to the second stimulation according with the embryo that we have. So when we have 3 blastocysts, or when we have less than 3 or more than 3. And we published this paper in which we combine patients with at least with the maximum 3 blastocysts, 1 or 2 or 3 blastocysts. And then in these patients, the discussion was, do you want to perform a second stimulation in order to increase your chance? Or we do the PGTA and then we transfer in case if you have a euploid embryo. So here you can see that if we compare Duostim versus 2 conventional stimulation, again, in Duostim protocol, you reduce the dropout, you increase the cumulative labor rate, you increase the percentage of the patients with more than 1 euploid embryo. Because the patients come to us not only for 1 embryo, not only for 1 transfer. The patients come to us to make a family planning. Family planning maybe means more than 1 baby. And this is also the case when we have patients with a monogenic disease. So if we have patients carrier for cystic fibrosis or for beta thalassemia or for genetic disorder, the Duostim seems to be a valid option. Because in this case, you need 5 blastocysts to have a good chance to obtain a baby. What about the cost? The cost is another important issue. But please, we have to analyze the cost, not the cost for the treatment. How much costs the baby? This is the same discussion for the gonadotropin, or the same discussion when we want to do something more in our treatment. Because if you look at the cost, two conventional approach versus Duostim, of course the Duostim costs more. But with the Duostim, you can have more embryo and you can have more cumulative labor rate. And so the cost will be lower. This is the paper that we published in some years ago with the ICER cost effectiveness analysis. So the evaluation of the cost is not easy, but we have to discuss regarding the cost of the baby, not the cost for the treatment. The last but not the least is the time. The time represents an important issue for our patients. This is the time between the first and the second stimulation. Look, when we do the Duostim or when we do two conventional approach. Look how much time we spend when we use conventional approach. So the patients need the time to restart again. And so this approach seems to be useful to explain from the beginning that you need more than one cycle. And this is a randomized control trial coming from Spain, in which we can see that the Duostim is a valid strategy to reduce the cost to obtain euploid blastocyst. Of course, if you want to take advantage from these strategies, you need an efficiency cryopreservation program. You have to try to individualize the correct drugs and the correct trigger. You have to, usually we use this approach in PGTA cycle. Of course, you don't need limitation in terms of regulation. And also, you have to be able to discuss with the patients regarding the putative chance for these specific couples. I spent 1 hour to explain this approach to my patients. This is the percentage of the Duostim in my centers. Look to the last year, we performed 35% of the Duostim protocol in my population. And look, the percentage is growing over the time. And also we have 10% of these patients that performed two Duostim. So first stimulation back to back. And 1% three Duostim. So this means that, in my personal opinion, the multiple cycle approach through the Duostim is something important in order to improve the cumulative chance, in order to reduce the time, in order to reduce improve the cost effectiveness, and in order to drop out rate. And if you remember, this was my first slides, and this was my last slides. And so, in my personal opinion, the multi-cycle approach is something that we have to discuss to our patients in order to try to improve the efficiency and efficacy of the treatment. I would like to thank all of you for your time, and sorry if I am over time. Thank you very much.
Thank you very much for your